Timer has been started, and here is your question. Right. So if you have read and understood, kindly identify the following. Which imaging is this? Can you please tell me?
This is most like the CT scan, the
Yes.
abdomen.
Yes. Actual CT scan. Can you please help me and identify structures
This,
A to E? What is A, please?
A, this is the gallbladder. B, this is the tract.
B is
And
what?
C, portal.
Okay.
And B, the portal vein.
Yes.
D is
D.
the left of the liver, and E of the back.
Okay. And what is E,
The
please?
left lobe of the liver,
E, please.
the tail of the pancreas.
Okay. Can you tell me what are the parts of
E is the
pancreas?
tail of
Can you name the parts of the pancreas, please?
the pancreas. There is the head and the neck and the body and the tail of the pancreas, and also there is part of
Body and the tail. Okay. Can you tell me what is the blood supply of the pancreas from three different sources?
the superior and inferior pancreas artery.
Yes.
The superior artery is from the gastroduodenal artery, and the pancreas from the subdental artery.
Yes.
And also there is pancreas branch from the artery.
From splenic artery. Okay. Can you tell me what are the ducts involved in pancreas?
There is a main pancreas, accessory pancreas.
Yes. Can you tell me where the main pancreatic duct opens?
It is open in the second part of the duodenal papilla.
Yes.
It's open just major duodenal papilla.
Okay. Can you
The
name?
main duodenal.
Yes. Yes. Can you name the ligaments which connect the tail of the pancreas to the spleen, please?
It's called the linear.
Okay, lenorenal ligament. Can you tell me what are the vessels which are encountered during Whipple procedure?
There is a short gastric
Yes.
vessels and
Yes.
the gastrocolic arch.
Okay. Any more? So if you can tell
And there
abdominal
is
aorta,
the
yes,
splenic
yes,
aorta, spleen,
yes,
and inferior pancreatic duodenal artery,
yes, yes.
and the lateral vein, and vein, and superior mesenteric artery, superior mesenteric vein.
Okay, very good. Can you tell me how the pancreas develops? Development of embryological development of
It is
pancreas.
arise from there is the ventral part, from the hepatic diaphragm. It gives the rise or the for the part of the head and synthesis. and there's on the dorsal aspect of the duodenum, it's the upper part of it, and the body and the head of the pancreas.
Okay, can you identify which organ is this? This tail of the pancreas enters or is attached to which organ? Which organ might be here?
The tail of the splenic hilum.
Spleen, okay. Can you tell me what kind of organ is spleen?
Mm,
Okay, can you
it
tell me the
is
blood supply of the spleen?
it is arise from splenic artery
Yes,
from the celiac trunk.
yes. And the venous drainage?
The splenic veins, which
Yes.
joins the inferior mesenteric
Can you,
vein
yes.
and to support vein.
Can you tell me the surface anatomy of the spleen, please?
Posteriorly, it is related to the lung and
Yes,
it is related to the 9 and ribs.
yes. Okay. And between position 9 to 11th rib, right? Okay. Can you tell me why is it important to keep in mind which structure during splenectomy? What is the importance of
Uh,
keeping in mind the tail of pancreas during
to avoid damage to the tail of the
yes? What might happen? What might happen if there is
the
yes damage?
damage depth,
Sorry.
there will be a pancreatic,
Okay. Can you tell me what
there will
what?
be leak from the pancreas
Okay.
to
Can you tell me what is the function of pancreas? What kind of organ is pancreas?
it has endocrine and exocrine functions.
Yes.
Endocrine for production of insulin and glucagon and
Yes.
and has exocrine function, which is pancreatic enzyme involved in hydrolyzing the carbohydrate and fat.
What is the importance of uncinate process of pancreas? It's part of which is it part of the body or part of the head or neck?
Mm, part of the head.
Okay, can you tell me what is the term pseudocyst mean to you?
It is localized collection of fluid,
Yes,
cerebral tissues,
yes,
pancreatic
yes. Can you tell the pathogenesis of pancreatitis?
where is there is when there is pancreatitis, there is a fluid either sac which is takes the stomach from
Yes.
the pancreas, lead to collection of fluid, which leads to the formation of
Okay, can you tell me what are the types of cells that are produced in pancreas?
there is a beta cells which produce the insulin,
Yes,
and A cells produce the glucagon, and these release the somatostatin.
and D cells somatostatins. Okay, good. Thank you so much. Bell has gone, but then just for the sake of leisure, can you identify this uh, image as well? Can you identify all the organs?
A inferior vena cava,
Yes,
B is the right arterial spinous, and
good.
C is the port,
Portal vein.
D is the right crust of the
Yes,
diaphragm,
yes,
E inferior vena cava,
Superior mesenteric artery.
E is the superior mesenteric
Yes.
artery. G is inferior abdominal aorta. This is the stomach.
G is abdominal aorta. Yes. Good. Yes. Good. Thank you
Yes.
so much. Here is your question, and yes. Right. If you have read and understood, kindly begin your examination.
Okay. Wash my hand. Hello,
Yes.
I am Mohammed Ryan, one of the exam candidate. Uh, After my I confirm your name and age, please.
Yes. 55 years old.
Today
Mom.
I have
Yes.
been asked to examine you patient, mom.
No, no, no patient. You tell, please.
Okay.
Yes.
Okay. Today I have been asked to examine your leg that include look and feel and moving the leg. Are you okay?
Yes. Continue. Yes, please. Continue.
Could you please close look to your leg? Inspect your leg from in front and from the back and from the side. Inspect for any distribution of the swallowing along the medial side or lateral side of the leg and the foot. Inspect for blowout and inspect for Safina varicose and inspect for lipodermatosclerosis and venous eczema and ulcer scar and atrophy branches. And inspect for any scar in the upper thigh, indicate above indicate secondary varicose vein. In primary varicose vein, the varicosity along the long saphenous and the short saphenous vein, and with sign of chronic ischemia like hemocyte deposition, venous ulcer, and lipodermatosclerosis. Then now I am going to feel your leg. I am asked the patient, do you have any pain at the moment? Feel the temperature with dorsum of your hand and compare from between two legs and palpate for lower limb edema and feel down the leg over the course of the long saphenous and the short saphenous vein along the medial side and the lateral side of the leg for any tenderness and compare the temperature and feel if any blowout like figantist. And then I am done. Tap on the lower part of the leg along the long saphenous varicose vein with one hand and receive the impulse by other hand. This is Schwartz test. If the positive indicate incompetent valve in the superficial venous system. And now ask the patient, would you cough for me to look for impulse in cough and feel for the safina varicose, indicate positive safina varicose. And then feel the sapheno-femoral junction by palpate 4 centimeter below and lateral to pubic tubercle for saphenofemoral junction and for saphenopharynx. If the swelling is present like the site with the palpable trill and cuff impulse, indicate incompetent valve between superficial and deep system. And then feel the trill with bulbar surface of your hand other than your finger. Now, would you please lay down for me? Now I am going to lift your leg and feel your leg. Do you have any pain at your hip? Now I am going to press here. Now would you please stand up for me? And now I am going to release my hand. This is Trend-Limberg test. Patient supine, 45 degree, lift hair leg and gently empty the fan like milky test to empty the fan, and then occlude the saphenofemoral junction and ask the patient to stand up to ensure the finger or thumb firmly over the junction. If the superficial vein not fill and the varicosity controlled at the level of the saphenofemoral junction by occlusion by thumb, this is indicate saphenofemoral junction. This is confirmed by or after release the pressure by hand or my thumb from the saphenofemoral junction, that the blood return from the femoral vein into the saphenous vein. And as the patient stand, if the vein fell from below, indicate saphenofemoral junction occluded and indicate incompetent perforator. Like this is Trend-Limberg test and the tourniquet test are positive the same in the saphenofemoral junction incompetence and the perforator incompetent. Now, would you please again lay down again for me? I am going to lift your leg again and I am going to tie this tourniquet. Would you please stand up for me? Then ask, could you please walk few steps for me in your place. Now I am going to release the tourniquet. This is tourniquet. This tourniquet test. I am done. Modified Bertus test. The same tourniquet test, but difference by modified Bertus test by occlusion by thumb and the tourniquet by occlusion by tourniquet. A test is done by applying tourniquet at the level of the saphenofemoral junction to occlude a superficial vein and ask the patient to move inside to if the deep occlusion and dilated vein increase in the prominence. The modified Bertus test, this is negative in primary and positive in the secondary test. And then I will perform multiple tourniquet tests the same by use one tourniquet, one tourniquet at the saphenofemoral junction and another above the knee and another below the knee, and ask the patient to stand and look for any prominent dilated vein. If any dilated vein, if above the knee indicate perforator, and if the below the knee indicate perforator, and after the saphenofemoral junction indicate saphenofemoral incompetent. And then now I am going to listen for any by the Doppler assessment by hold the Doppler probe at 45 degree angle to the skin at the level of the saphenofemoral junction, squeezing the patient by calf at the in patient with the saphenofemoral junction incompetent. I am here short swatch during squeezing the calf muscle. If the saphenofemoral junction incompetent, I am here more prolonged like swatch of the blood. This is indicate incompetent valve. And then ask the patient to done Bertus test to look for or indicate deep femoral vein patency by Bertus test, but this is test not done. And then thank you, sir, and you might rest now, and do you need any help? And wash my hand.
Okay, can you summarize your case now? What was your provisional diagnosis?
Yes, 55 years old male, complain of the swelling, bulging of the vein in the both lower limb since 5 years. In the recent month, associated with progressive leg pain, which redness and continuous daily activity. He is a smoker and alcoholic, and his sleep and appetite normal, and no positive family history.
So what was your provisional diagnosis for this patient?
Yeah, differential diagnosis could be primary varicose vein, could be secondary varicose vein, could be chronic lower limb ischemia.
Okay. So what investigations would you do to confirm your diagnosis?
Yeah, the investigation like venous duplex and the duplex ultrasound can be determined the site of valvular incompetence and the dependency of the deep venous system.
What are the management options that you can offer this patient?
Yeah, the management after history and examination and the investigation depend on the symptom and the effect on the quality of life. Could be
Yes.
conservative, could be conservative like graduate compression, stocking, exercise, leg elevation, avoid of the prolonged sitting or standing, and invasive non-operative foam sclerotherapy, radio frequency, and photocoagulation and ablation, and the invasive operative under general anesthesia. Like stripping and the excision of the lung saphenous vein.
Okay, good. What other things would you do to complete your examination?
I will examine the arterial system examination and the abdominal examination to look for
Very good.
any sign or associated for or any abdominal mass or any aneurysm.
Very good. Yes. Thank you. This was it. That was the only thing you missed. Thanks. Good.
Okay, thank you, ma'am.
Started the timer, and here is your question. Right. If you have read and understood, kindly tell me by looking at this, what do you think your provisional diagnosis would be?
So my professional diagnosis would be first, I would think of basal cell carcinoma.
Yes.
Then I will also think of squamous cell carcinoma,
Yes.
possibly malignant melanoma because of the location also.
Yes.
Then I will also think of actinic keratosis and
Yes.
seborrheic keratosis.
Can you tell me what is the mode of spread of basal cell carcinoma? How does it spread? What are the stages or steps?
Okay, so it's spread locally.
Yes.
So, and of course, it rarely metastasizes, but it could.
Yes.
So, and in that case, spread through the lymphatic vessel.
Right.
So, and also through the blood vessel through embolization.
Okay. So what are the 5 major steps or the steps that are involved in the metastasis of basal cell carcinoma?
So, okay, stepwise.
First, invasion. Okay. Yes.
First thing is look. First, there will be invasion of basement membrane.
Yes.
Then there will be local invasion of local tissue.
Yes.
Then
Infiltration. Yes.
Yeah, tumor will secrete growth factor that promote lymphagenesis locally. So
Yes.
ingrowth of a lymphatic vessel and a blood vessel, new
Yes.
blood vessel and a lymphatic vessel. So, and the tumor will now invade the lymphatic vessel and the blood vessel. So from through the lymphatic vessel, it will transfer through the afferent lymph node, lymph vessel to the regional lymph node before continuing with the efferent lymph node. Whereby through the blood vessel, it can seed into the blood vessel, and from there, triangulation can spread to the secondary site. So,
okay, can you tell me if you'll do the biopsy, what type of biopsy would you prefer for basal cell carcinoma?
okay, additional biopsy.
Yes.
So,
okay.
We can do, yeah.
Yes, please. And if you've done biopsy, what are the findings that you expect to find in the report, biopsy report?
Okay, for biopsy, I want to so first of all, I want to check the cytology wants to check for the mitotic index.
Yes.
Degree of the differentiation.
Yes.
Then the cellular features, whether
Yes.
that's atypical mitosis and increase in the cytoplasm and the nucleus ratio and other cellular features. Then I also want to check for the histological features such as the infiltration of local tissue.
Yes.
Then I also want to check the margin, then whether there's presence of lymph node, whether the margin is positive or negative.
Yes.
Then presence of a lymphatic invasion or vascular invasion. Then, yeah.
Can you please tell me what is the natural history of basal cell carcinoma?
Oh, so it grows in the sun or exposure site.
Yes.
Then it grows slowly, so it's indolent in nature.
Yes.
So which means slow progression.
Yes.
And it has a more aggressive pattern locally.
Very
and
good.
really metastasize.
Can you please tell me what should be the treatment of basal cell carcinoma?
So for basal, okay, never metastasize. Okay, really. So basal cell carcinoma, the treatment option, of course, we have a excision, that's the surgical treatment. So
yes.
for the surgical treatment, also we have a removal surgical excision. Then we have
yes.
the use of tropical agents, the use of radiotherapy.
Yes.
So for the surgical approach, so we can use a sheath biopsy, we can do curettage, then
yes.
we can do we can also remove using cryotherapy.
Cryotherapy, yes.
Then
yes.
we can also use what they call it most microsurgery.
Yes.
So with frozen section.
Yes.
And then
what radiotherapy options can you offer?
Yeah, local radiotherapy. I don't understand. Yeah, I can offer radiotherapy locally because it responds to radiotherapy also.
For this patient,
other topical,
yes. For this patient, what excision margins are you going to keep in your mind?
Okay, so I'm going to use at least 1 centimeter margin.
Okay.
For this patient.
Okay. Can you please tell me how would you differentiate it from squamous cell carcinoma? What are the features that you'll consider?
Okay, so first the appearance.
Yes.
So for squamous cell carcinoma, we have sometimes we have ulcer, not healing ulcer.
Yes.
Then squamous cell carcinoma, unlike basal cell carcinoma, then on histology. So basal cell carcinoma arises from the basal membrane, basement membrane, whereas squamous cell carcinoma arises from the superficial epithelium, so the keratin-producing cells of the superficial epithelium of the skin. Then that's histologically. Then squamous cell carcinoma always metastasize distally, whereas basal cell carcinoma never metastasize distally. Then
yes.
appearance, so squamous cell carcinoma always have elevated edges, so with ulcer in between, not even ulcer. Whereby basal cell carcinoma always have a purely what do you call it? Purely purple color with a background telangiectasia. So which causes redness on the background. So that is also another major difference.
Which carcinoma is more dangerous, basal cell carcinoma or squamous cell carcinoma?
Squamous cell carcinoma is more dangerous.
Okay. Both are exposed, both are caused because of exposure to sun. Then how
yes.
would you make sure, depending upon location, which cancer is which? Which carcinoma is it? Is there any difference in location on the face or anywhere?
Yeah, I think
Or which one is more common, if I could ask you? Basal cell carcinoma
Yeah.
or squamous cell carcinoma
I would say squamous cell carcinoma.
is more common. Okay, good. All right. What are the complications that you expect to find when you're managing a patient with basal cell carcinoma?
Oh, complication. So
Yes,
first we can have a local complication after surgery like infection,
yes,
then delayed wound healing. Then we have a complication of radiotherapy. So like a delayed wound healing, or yeah, also. Then we
yes,
have yeah, we can have a abscess after removal. So abscess also, which is part of it. Then metastasis, which is more aggressive.
yes.
And then yeah, those
If
are the
there is
major.
if there is an infection which is not healing after you have excised basal cell carcinoma, so what would you expect the most common organism to be?
Yeah, it will be most common of these staph aureus.
Yes. How would you manage that?
So okay, so
Yes.
I'll manage
Post-operative
that
infection.
also. Yeah, so first of all, by doing proper debridement of the wound and probably link the wound for secondary healing. Then I also check the abscess or the content, send it for pathological culture to know which bacteria is present and to address antibiotic therapy directed to the bacteria according to sensitivity test.
Yes.
Then, of course, to always clean the wound following normal aseptic rule. And if the presence of the MRCS, then
Yes.
I will treat accordingly.
Yes.
If
For this patient, like post-operatively, would you consider skin graft, or would you rather allow it to heal with secondary intensive care?
so,
Last
for this
question, ma'am.
patient,
Yes, for
yeah,
this
for this
one.
patient, the size of the lesion is okay in the nostril. So
Yes.
I can use a rotated skin graft.
Would
If
you
there's
use
no
a
risk
graft or a flap?
flap rotated,
Yes. Yes.
that one that will rotate from the forehead
Yes.
to already the defect.
Very good. Excellent. Thank you. Good. Thank you so much.